And I think Dr. Julius is our first case. So, yeah. Okay. Once again, good evening, everyone. Thanks for joining into our year-end session. Once again, thanks, Dr. Swasni, for joining us as a panelist. Again, as always, and Dr. Mankad will be joining us later. We have around 11 cases with 2 follow-ups. So we'll go ahead with our first case.
So this girl is symptomatic from last 10 years. She is now 13 and a half and she's symptomatic since 3 years of age. And she's been extensively worked up. So there is a video after this slide. So that's what she develops. The paroxysms of dystonias lasting for few minutes to hours. And these movements are quite painful. In between these episodes, when she was in the early childhood, the examination used to be fine. But gradually she developed dystonia even at rest. But these paroxysms used to be over and above that baseline dystonia and some mild intellectual disability. So in these 10 years, she underwent a metabolic workup and an exome and a mitochondrial genome. Both of them were negative along with TMS, GCMS. And she was so far undiagnosed until we repeated an exome this year. The first one was in 2015. So when we did a literature search, some of the genes were recently described like ECHS1. So we repeated the genetic study because they were not there in the gene list sent in 2015. So this year's exome picked up DLAT.
Dr. Jui, maybe we'll get to the result later on after
right.
the case. Yeah.
Right. Sorry. Okay. So maybe we can see the video. So this is, so they are from a family, they are from a Muslim family and they, there are multiple consanguineous marriages in the family. So the index case is also a product of consanguineous marriage, second degree consanguineous marriage. And she has a cousin who is similarly affected. Yeah, this is the video of that girl. This is a couple of, I think, 1 or 2 years back. She usually comes walking to the clinic, so she can walk by herself. But this is how she is during the episodes.
All right. So yeah, the clinical.
Yeah, so we had kept a lot of differentials along the workup, but because of the negative genetics and all the metabolic workup, we were not able to reach a diagnosis, and the radiology will follow.
Sure. So we have two scans around 2 years apart. So this is the first scan in 2012. We have only the images from the film. As you can see on the T2 axial images, there is mild cerebral atrophy, generalized atrophy. But the primary findings are in the bilateral globi pallidi, which are edematous and bulky, demonstrating symmetrical T2 hyperintensities. No other signal changes in the brain, nothing in the posterior fossa, and no structural malformations per se. So primary abnormalities were in the bilateral globi pallidi with some degree of cerebral atrophy. 2014, again, we have similar appearance of the deep brain nuclei, that is the bilateral globi pallidi. We have a diffusion sequence, which also demonstrated restricted diffusion. There was reduction in the corpus callosum volume, and again, no other signal abnormalities in the brainstem or the cerebellum, given these quality of these images. So primary findings were in the bilateral globi pallidi. Imaging differentials for the globi pallidus hyperintensities, especially if they are bulky and edematous, demonstrating restricted diffusion, one would think of mitochondrial disorders belonging to the pyruvate dehydrogenase complex and the fatty acid disorders, as Dr. Jui has mentioned. Another possibility is beta-ketothiolase deficiency, but clinically, I don't think it matches with the anorganic acidity representation. The rest of the differentials usually demonstrate some degree of volume loss or are not bulky, as seen in our index case. Yeah, Dr. Jui.
Yeah, so the repeat exome showed a homozygous mutation in the DLAT gene, which is autosomal recessive. So given the radiology, the clinical picture, and there is a consanguineous marriage and a first cousin being affected. So although it is reported as VUS, but it seems to explain the whole picture. So, and clinically, therapeutically, we have already taken her on thiamine and a mitochondrial cocktail. So I wanted to know the panelist opinion if it does fit in.
Can I come back to the history? When did the situation start? 3 years ago or at the age of 3 years?
At the age of 3 years, 10 years
Okay.
ago.
Did you try before any, say, sodium channel blocker or whatever, like carbamazepine, which sometimes helps in paroxysmal dyskinesias?
Yes, they were tried. I think Dr. Nihaal, you would have a slide also of all the drugs which were given sequentially.
Yeah, I
So,
didn't put that up. Sorry.
okay. So in the, I think, 3rd or 4th year of diagnosis, she was kept as those PNKD, PKD spectrum. So she was given carbamazepine, but there was no response.
Thank you.
It would be consistent with pyruvate dehydrogenase, what we are seeing on the scans, both the cerebellar finding and the palatal finding as well, as much as I can remember of the various possibilities. So the only thing is that the geneticists will not let you make that variant significant. You'll have to do it clinically because imaging doesn't have a role in that process.
Okay. I was thinking that maybe she has a first cousin affected. So if I can arrange some funds to test that girl and the parents, maybe that's how we can connect.
If I'm not mistaken, some cases of PDH respond to ketogenic diet.
Yes. So that's what our plan is, that we have counseled them for KD and they've agreed also. So we do plan to take her on ketogenic diet.
Thank you.
All right, thank you. I think that's almost a match, Dr. Joy. So
Okay, thank you.
Yeah.
That was very
Right.
helpful. Thank you.
thank you. The next set of cases are from Dr. Vivek. I hope he's able to join us.
Can you hear me?
Yeah.
Okay. So this is a boy who I've just seen a month back, who had I think 1.5-year-old boy who had ichthyosis at birth. There was some. Did you get the pictures, Nihaal, from birth?
Yeah.
These are from now. So yeah, so ichthyosis at birth. He was not like a collodion baby. Ichthyosis was more in the flexural areas, and gradually that receded. And what he was left was, in the previous frame, if you go back, he had more of a palmoplantar keratosis and hypopigmented blotch spots on his abdomen, and so hypopigmented with hyperpigmented sort of alternating spots on his whole abdomen, and just distal palmoplantar keratosis. He does have significant delay, which is more motor than cognitive. He also has spasticity in his legs with hyperreflexia, but cognitively he's better. So it's not, sorry, he's 12 months, and he interacts well, he responds to his name, good eye contact, arms are better, but legs more in a scissoring gait. So a baby who had ichthyosis from birth, which has receded now, left with skin changes and some distal involvement, and it's more of a diplegic sort of neurological profile. No seizures.
Yeah, so we go on to the images. This is at the age of 10 months. On the T2 axles, you can appreciate that the white matter is hyperintense, abnormally hyperintense for the age. There is some degree of myelin abnormality over there. delayed myelination going on in the bilateral cerebral white matter, subcortical regions predominantly involved, also the deep white matter. The basic ganglia are slightly hyperintense, but not very significant. The anterior limbs also are not myelinated. There was some 2 foci of extra axial hemorrhage right on the right frontal region and along the anterior aspect of the vermis over there. Cerebellum did not demonstrate any atrophy or signal abnormalities. On the T1s, there was slight delay in myelination, but not as significant as on the T2s, possibly suggesting a hypomyelinating type of a disorder. Again, these hyperintense foci are the extra-axial hemorrhages, and also some ventricular predominance with reduction of periventricular white matter volume. Going back to the axial images, you can also appreciate that the eyes are also small, so there is some microphthalmia on both sides. SW images better demonstrates the hemorrhage, some subarachnoid hemorrhage in the vermis too. The corpus callosum is diffusely thinned out, some degree of volume loss in the midbrain, possibly in the pons. Angiography did not demonstrate any thrombosis or aneurysm or stenosis. So clinically, at least, these are the differentials for ichthyosis. To list out, here are the differentials. They can be primary or syndromic. Imaging wise, with white matter disorder or myelin deficiency, the underlying ones were the closest match. Multiple sulfatase deficiencies, Jorgen-Larsen syndrome, trichothyroid dystrophy with ichthyosis, which can also have microphthalmia, was another close differential. So these were the findings on the MRI which you thought of. So I'll open the case for the panelists to discuss on the clinical and the imaging findings.
Nihaal, I have a question about the imaging. How confident are we? Sorry, I might have missed a slice or two. There's no fat in there, that we are calling the whole thing hemorrhage.
Yeah, possibly, but I didn't have a outer phase image there. So it could be fat, yeah. But there's some subarachnoid, yeah, that also can be fat signal, yeah.
Because if there is fat, then we're thinking about mosaics. Given the skin problem, you have to screen for mosaics. How confident are we that this is hemorrhage? Do you have a CT or something?
No, I don't have a CT.
No.
And then we're talking about the spectrum of ECCL with the skin problems, but in the spectrum of mosaics. And Julia has a relevant question. I don't know how many sequences there are, Julia, but I'm just thinking if there is a little bit of fat thrown around there, not just hemorrhage. And the leukodystrophy-like changes would also be then consistent with some kind of mosaic. It looks like a big head to me. Maybe that's why the eyes look small. So maybe there's a macrocephaly. That cerebellum is quite big as well.
Mm-hmm. Dr. Reddy, do you have the head circumference?
He does have a large head as compared to his body. So okay. That's it. He has got, he's macrocephalic. Yeah, the peripheral rim, will that go with the fat? Or more with hemorrhage?
It's more hemorrhage, but I think I just saw the susceptibility because it does throw susceptibility as well, even if there is fat in there. It could be a mesh of abnormal vessels with fat, to be honest. That is possible as well. But the chemical shift artifact can also be seen from fat. We have to be mindful. I don't know if it's all hemorrhage out there. It could be useful to do a CT if you can.
Sure.
There is a panel of mosaic screening. I'm not sure what's existing in India or there. I can connect you with the people here at Great Ormond Street. In fact, we had a discussion exactly about similar things on Wednesday this week.
I'm not with you, Kesh. What makes you thinking of a mosaic?
So the skin problem, The overgrowth of the brain, the cerebellum is quite large as well. That sagittal is quite interesting. You just had put that there, for instance. It's a macrocerebellum.
But
And then we have
yeah.
potential fat mixed with some abnormal blood vessels in that location. So just thinking laterally in terms of a neurocutaneous problem.
But the initial presentation was whole body skin change. And the hyperpigmentation is kind of residual. No?
I don't know much about the skin side. But that also happens in mosaics. I mean, in any of the skin problems, they may be born with quite an extensive change, and that can shift, right? Does it always have to be Blaschko's and things like that?
Definitely not.
Dr. Romit has a question of short stature or rhizomelia.
Well, I haven't. For his age, he doesn't look short. Like I haven't taken his length. He's not big enough to. So, like, he looks big enough for I think he was 13 months. So, as for rhizomelia, he does appear to have a short neck, and his. I've not checked his arms to the side if he's rhizomelic. But is there something in mind? Short stature, rhizomelia, ichthyosis. More like a Romit?
It's rhizomelic chondrodysplasia.
Rhizomelic chondrodysplasia. Yeah. It does have ichthyosis, right? Is that right?
Yeah, it does have ichthyosis.
Mm-hmm. So that we can, because he does look like a child who could have a skeletal dysplasia by his body stature.
Dr. Kavita is asking if it's a possibility of Jorgen-Larsen syndrome.
The MRI changes, are they suggestive? They're not suggestive.
It's suggestive of delayed myelination at this age of 10 months. So it can have myelin abnormalities and kin corpus callosum, but the only thing was the fat and the hemorrhage. Dr. Gopi says that the MRI is fat suppressed and it's not showing up on that, so it's likely hemorrhage. So yeah, I think that could be a possibility. But
I think Jorgen-Larsen will have more changes, like more extensive white matter changes, like a demyelinating kind of a pattern.
Yeah, but this is at 10 months, so the child has not myelinated yet.
Yeah.
So that's
I don't think we can explain the eye changes and the kind of and more extensive ichthyosis.
I've seen one single Sjögren-Larsen patient. The ichthyosis is confined to the great folds, axilla, elbow, and so on, and is extremely itchy, impairing quality of life, unless you have a very special, very expensive treatment, which is not really available due to insurance constraint.
His lesions are not itchy, like he doesn't have any, they're not itchy. And does the clinical neurological presentation is at a later age with Sjögren-Larsen after a few years of age? Initially it is more skin, like this child is too young, because I've never seen a child.
They can have early delay and early spastic diplegia. Later on, they can have few infrequent seizures.
Right.
But spasticity is going to be quite severe. That will progress over a period of time. But short stature is not part of this syndrome. I think we can, we'll have to look up on the aspects. We'll move on to next question.
Dr. Are you getting a genetic study, or what's the plan?
Yeah, like the family, I'm not sure if they will get it done. So I did mention that to them. So they will come back to me. We haven't said it still.
Okay. Okay. Thanks.
Yeah. So this is a 3-year-old baby who was a twin delivery, small for date, and was in the hospital for 15 days, but did not have asphyxia, no seizures, not ventilated. And then the child had come earlier to me, and now this time and has global delay, and now is dyskinetic, hypotonic, hyperreflexic, but with somehow dystonic with striatal toe, but very good interaction with his family, and so good eye contact, but more of a truncal hypotonia, distal dystonia, a degree of bilateral esotropia, and subtle dysmorphism, small ears, bulbous nose, as we can see here in the video. So, and we had a homocysteine uric acid, which were normal. I hadn't done any more tests. I was going to discuss the MRI, then plan.
Just the age of MR, okay,
2-year age. 2-year age. 2-year age. So there was a lot of confusion in the age. So it's 2-year age.
Yeah, because over here it's 8 months on the film, so obviously if it is 2 years or 8 months. It's at 2019.
Right. So then it must be 8-month-old. So were there two MRIs?
No, it's only MRI.
Single MRI. So maybe so then this is 8 months and 8 months age.
Yeah, because 2020, it's 8 months.
Right.
So you had mentioned the hypomyelination, but at 8 months it would be slightly difficult to comment upon. At least the GNU is not myelinated completely on the T1 VD sequences. Basal ganglia also appear slightly small for otherwise a normal basal ganglia should be slightly more elongated over there. No structural malformations. Corpus callosum is also slightly thin, and there is some degree of craniovertebral junction narrowing, but I don't have other in the video to comment upon that. Other than that, I cannot appreciate any other findings. So maybe some mild delay in myelination and reduced corpus callosum volume with reduced craniovertebral junction space over there. Without the second MRI, I'm unable to comment upon the imaging findings. So I'll open the case for the panelists.
There is no diurnal variation and there is no tonic. So he doesn't have oculogyria. And
I agree with you, Nihaal. I wouldn't call this hypomyelinating. There might be a paucity of volume supratentorially. I think the corpus callosum is thin, even for 8 months.
Yeah. I think that 2-year scan was showing hypomyelination. Is that right, Dr.
Yeah, because I thought it's 2. So the second one, there wasn't, there was some progress, but not a lot. So I think I haven't seen that.
Okay.
So it probably looks similar to this MRI.
Okay.
This one was done from outside and that one was a one which I got done.
Okay.
So if that is 2-year stage MRI, then it will be hypomyelination, right?
Yeah, if it has there is still myelin is not completely formed.
Yeah.
Possible. Yeah.
This thyroid function I hadn't done. So Allen Herndon, Dudley, and those things comes to my mind. So I haven't done many investigation, homocysteine and uric acid only, which are normal.
So
I just do it for all.
Yeah. Clinically, there's no clinical handle to suggest anything particular.
Just subtle dysmorphism and bulbous nose, broad face, and distal dystonia.
Okay, I think the second MR would have been.
I was thinking if it still could be, I mean, I know you've got a normal uric acid, but in infants, I mean, the excretion can be a little erratic. So it could still be Leschny-Hans if he might start the self-mutilation later. Like I'm not sure about the hypomyelination part because the other things could still fit. So maybe repeat uric acid or, of course.
Nihaal is not on my list of delayed myelination.
No, I'm not sure about the, because this MRI, we were not sure of the delayed myelination.
Okay.
So if the MRI is like normal, then it could still be fitting in, I guess.
So the uric acid levels, usually they give the adult levels. So for pediatric age group, the levels are lower. Is that right? So asking someone has to check that. And his was bang normal.
Yeah, I was just thinking, yeah, sometimes a repeat. But of course, he should be developing self-mutilation by now. If he's got teeth, and yeah, that's the next thing. It's 2 years plus. The repeat MRI, if it's definitely showing hypomyelination, then Nihaal is out. They will have a normal MRI, probably maybe just mild atrophy, I guess. The radiologist can correct me if there are findings.
And thyroid was normal, probably done it already. So thyroid was okay.
Okay, maybe we'll move on to the next case and have the follow-up imaging on the next session.
Right.
Yeah.
So he's a neonate. He's now around 15 days age. He was he had birth asphyxia, but that was not documented from the local hospital. But there were some clinical handles because he was irritable till day 3, 4. And on day 4, he had fever with seizures with normal sugar. And so details of delivery are not really clear. And the local hospital which transferred to our hospital just said the child became unwell on day 4 and query meningitis. But then we had done a LDH and a CP. LDH was raised and CPK was raised as well. So there were some handles, so he might have asphyxia, some issues with delivery. His initial CRP was raised. His CBC showed 72,000 white blood cell counts, which have normalized. Or he shed platelets on day 4, 5 was 15,000, which is also now recovered. His coagulation was normal, and white cell counts are also normal now. So he was just, he's not ventilated. He's clinically improving, but there was an ultrasound done which showed bilateral temporal bleeds, and hence he got an MRI done subsequently. So which shows the changes.
Any abnormalities in the liver, Dr. Ved? Hepatomegaly or any liver enzymes?
So no liver dysfunction, except for no liver dysfunction and no renal dysfunction.
Got it. Yeah, so this is the MR images at day of life 9. And you can appreciate there are some foci of hemorrhagic foci in the frontal regions on the right side, but the predominant findings are in the periventricular, peritrigonal white matter. You have these large, almost confluent areas of cerebellar hematomas extending in the temporal lobes, going up to some region of the occipital lobes on both sides. Sagittal images, I cannot appreciate any posterior fossa hemorrhage, but the vermis appears slightly small. Brainstem is also slightly reduced in caliber over there. Again, on the T2-weighted sequences, diffuse white matter abnormalities, especially in the posterior cerebral hemispheres on both sides, with these large hematomas and almost some radiating appearance of these linear foci on the T2-weighted sequences in the region of the medullary veins. At least on the SW images, there were no orbital hemorrhages. Yeah, again, the SW images better demonstrate the large hematomas in the bilateral temporal lobes with some medullary vein injury over there on both sides. Some subdurals around the posterior fossa, not significant. Again, diffuse excitotoxic brain injury, predominantly in the posterior cerebral hemispheres, also involving the corpus callosum and the anterior periventricular and frontal subcortical cortical regions. MRV was done, which did not demonstrate any thrombosis or cyanosis. There was focal areas of narrowing over there, but as there is flow in the proximal sections, wouldn't consider that to be significant. So based on those findings, the main causes is a paper from Dr. Mankat himself. And these are the causes which to be considered for a neonate with hemorrhage. Bleeding diastasis is most common. Infection also is another possibility. And associated deep medullary vein thrombosis, again, this is an image from Dr. Lokesh. So yeah, these causes which were thought of, and with associated medullary vein injury and ischemic brain injury in the bilateral cerebral hemispheres. I'll open the case with panelists. Dr. Vivek, if you have any particular questions.
So it's more whether it was a difficult delivery which has not been told and that caused the hemorrhage, especially the subdurals, or it's the thrombocytopenia of 15,000 sepsis with thrombocytopenia, which could have led to this. So these were the two things.
Yeah, I think it's concordant, isn't it? This is what we would get in a DIC kind of situation on imaging.
Right. So sepsis with DIC. His coagulation was normal.
Yeah. And did you have any cardiac problems, murmurs or something, vegetations in the?
No, he had an echo. Echo was normal. He did have echo.
No temporal lobes, just Dr. Kavita has asked the question.
So the one important thing is you said it's a leukemoid reaction. If you just go back to the initial slide. Okay, that's just a raised white cell count, isn't it? Okay.
Yeah.
I think the low platelets must have been instrumental, which was initially low and then recovered on their own, right?
Sure. It's just because there was some medico-legal connotations. Your family was saying that delivery time must have been a problem. They often so it's useful to inform them.
Yeah, it's not the pattern that we see with traumatic birth per se. And even if we say there was birth asphyxia, this is not the pattern that would fit in any of those subtypes.
Yeah.
So I think the thrombocytopenia would have been more instrumental than anything else.
Yeah. We did do a dengue as well, which was negative. So because that's something which came to mind. It's fever and high CRP and low platelets, NS1 negative.
Question of torch profile.
No, we didn't do that because we didn't consider that as a possible torch. Specifically, which one? CMV, is it? Or herpes? So usually they have perinatal insult will have a liver dysfunction as well. Like this doesn't look like that.
Yeah,
though.
yeah, it doesn't look like torch. So
Yeah.
not the typical ones. Okay, so thrombocytopenia and possibly hemorrhages, and not typical for birth-related injuries.
Okay, thanks.
So, is there any way to differentiate the timing of bleed? Like, I mean, they say the perinatal bleed, trauma would have been on day 1, and if this is happening at day 4, just a question. Or if you look for other associated, features of trauma, because a legal question, if we have some more facts to look for, just a question to the radiologist is possible.
Nihaal, you're happy aging the blood products there?
Yeah, there's a mnemonic for it, but yeah, so if it's iso-intense on the T1s and hyperintense on the T2s, it's hyperacute. But these are in the T1, they're showing T1 hyperintensity with T2 hyperintensity. So it is in the subacute stage. And up to the early subacute stage, they have restricted diffusion. Here only central areas have restricted diffusion. The peripheral regions do not have restricted diffusion. So more in the subacute stage, which ranges from 7 days onwards, is what I would place my bet on.
Yeah, it's a rough estimate.
Yeah.
It could just be the end of the early subacute stage.
Yeah,
as well.
yeah.
Thank you.
All right, thank you. Next, please.
So again, this is a neonate who had HIE2 with seizures on day 2, and then he was improving on CPAP, but then he deteriorated day 10 when he developed sepsis, Klebsiella positive normal CSF. And since then, now he's actually 5 weeks. So we've not been able to wean him from ventilator. He's alert, good facial expression, tone is less, but he has preserved reflexes. So he did have absent reflex initially, but now we have checked they're preserved. So knee and ankle. So that when I wrote this, put it on, I wrote absent knee jerks, but the reflexes are preserved. So the dilemma had been why, it's because he's not behaving like a child who had HI, because they don't have problems for weeks on and become ventilator dependent. So we did a CPK, which was normal. There was reason we did his torch. Because of the MRI, there was some suggestion it could be a CMV, though it didn't look like that, but we still did it. It was normal. So there are some MRI films, and so we don't have a reason why he's still ventilator dependent, even though he's so alert. And there is no suggestion of a myopathy as such. So the changes in the MRI I want to discuss, are these changes significant enough? He does, so that's why I put it on.
Yeah, so the MR on day 21, on the axial images, you can appreciate that the white matter is slightly hyperintense, which corresponds to a slightly lower signal intensity on the phase sequences. But that can be also seen in unmanaged brain on the phase sequences, which are pitfall. But there is some areas of rarefaction in the frontal regions over there. The ventricles are enlarged, possibly some reduction of the white matter. Could not appreciate an obstruction of the along the fourth ventricular third ventricle on the sagittal images, which I'll show in the next slide. No structural malformations per se, but the white matter appears slightly hyperintense for a neonate at 21 years of age with ventriculomegaly. On the diffusion weighted sequences, this is artifactual going across the third ventricle. Some subdural hemorrhage along the posterior fossa on both sides. Some tiny areas of hyperintensities, other which do not correspond with those signals on ADC, so I don't think they are significant enough. And yeah, here's the sagittal images. Again, the corpus callosum is slightly hyperintense than what would not be expected. Brainstem is also hyperplastic. The vermis also demonstrates slightly reduced height. No obstruction of the CSF flow along the aqueduct. The fourth ventricle also slightly prominent, with a prominent cisterna magna out there. They have symmetrical hyperintense changes in the posterior putamen and the ventrolateral thalami, likely related to post-hypoxic injury. Again, subdurals can be appreciated in the SWA sequences. The question was, is it a genetic disorder? I could not point out to a particular diagnosis on the MR images, but this is a case from Dr. Vivek himself, which had these edematous or hyperintense white matter changes with the corresponding flare suppression. This was a day 45 scan. The other scans or differentials with slight refractory changes are interferonopathies, CMV, rubella, vanishing white matter, mitochondrial disorders, and MLC. Less likely possibility given that the absence of cataract or organomegalies was galactosemia, which can also have these diffuse changes in the cerebral white matter. Homocystinurias, just to be ruled out, they usually present with diffusion restriction in the acute or early subacute stage, which they not scan. So these are the imaging differentials which we thought of, but could not point out to a particular diagnosis on the image, on this image.
Because there were some confusions about, so he does have secondary insult in form of asphyxia, but he also has this ventricular prominence with cerebellar atrophy and brainstem being hypoplastic, so which really confuses the issue as what this could be. His homocysteine was normal. It was not low or high.
Yeah.
So does he fit into the one of the pontocerebellar hypoplasia spectrums? Like they can be quite hypotonic.
Right. And the ventricular prominence, will that?
Nihaal, can you show coronal images, or I have missed it perhaps?
There's no coronal images, right?
I'm not impressed about the cerebellar volume reduction. I wouldn't call this pontocerebellar hypoplasia. And I think these images don't explain why this baby is not off the ventilator. And also the differentials which you showed subsequently, these babies breathe normally.
And
Vivek, I just had a thought. I mean, of course, those babies will not have any imaging abnormalities, but sometimes maternal myotonia and maternal myasthenia can lead to prolonged ventilator dependence and weakness in the babies. So, and the mothers can be quite mild. So those are things. If we can't explain the ventilator dependence on this.
so facial expression should not be good, right? Because facial expression is affected in newborn myotonic babies, right? Because they usually have a very long face.
They have a long face, yeah.
So it's not there at all. It's like a normal term with good cry, and
He's just ventilator dependent.
and he doesn't have distal weakness. If I would say he has more of a proximally weak, if he is a bit.
Yeah, the neonatal, ones can, I guess they can have proximal weakness. Yeah, but it does have so many things in the brain which is hard to ignore. Yeah,
So if he has a small hemorrhage, can this ventricular prominence be due to some bleed intrauterine prenatal, and now it's left with a hemorrhage? Are there any hemosiderin deposit? I didn't check that anywhere.
This is the post. No, I couldn't find any hemosiderin over there. This is just a vessel over there and nothing in the fourth ventricle or around the foramina.
Sure.
The only hemosiderin was along the subdurals, which can be birth related, but yeah, other than that.
And those white matter changes, they are not explained by any postnatal issues he has at the moment, right? In the fifth image, first image in the second line, second row.
Yeah.
But like that's more than one can see normally, right? In a new.
Yeah, I mean the white matter is slightly hyperintense than what one would normally expect.
Would you say it is rarefied? Rarefied slightly.
The only thing in neonates and the infants, the flare demonstrates these low signal changes. So that's actually a pitfall, which we usually don't screen childs with on flare sequences at least up to 1 year. But yeah, at least over these frontal regions over there, they're slightly more closer towards the CSF intensity than the other areas.
Right.
But yeah, I'm unable to point out on the imaging itself a particular diagnosis.
And the degree of brightness in the first row, the first three images, that the hyperintensity of the white matter, will that be normal, or that is more than normal?
It's more than normal. That's why I mean slightly more hyperintense than what they were expected at this age. But that can be presented just by edema or some encephalopathy or something like that. It's very non-specific.
Even HI can have that, right?
Only white matter range. Such a diffuse pattern without gray matter involvement, I wouldn't think so.
Right.
The cortex is relatively spared. So.
Right.
Usually the channelopathies can also have them, but this child doesn't present with like a sodium or a potassium channelopathy related disorder.
So CPK is normal. There was a mention about merosin.
Yeah.
That's a dystrophy, not a myopathy. So.
Maybe a follow-up imaging after 6 months or so can help. I mean, though we have to treat the child acutely now. If those white matter changes resolve or progress into more rarefied appearance.
Sure. That's fine.
All right. Thank you. Next is Ramani, if you're there.
Yes, sir. Am I audible?
Yeah, go ahead.
So this is a case of a 5.5-year-old girl born of non-consanguineous marriage, normal birth and developmental history. She came to us in the last year, May, with one episode of unprovoked seizures in the school, like a sudden loss of body tone and with slurred speech, and also it lasted for a few seconds. That time the semiology was query seizure or query stroke-like episode, but then with preserved awareness, and such episode lasted over 20 episodes occurred over 48 hours, for which she was admitted. And And EEG was done, which showed right hemisphere showing excess delta activity with no definitive any spike wave discharges. So MRI has been done last year. That was a post-ictal only. So please show that MRI.
So yeah, no hemiparesis previously?
No, sir.
Okay, so there is a focal abnormality over there in the posterior putamen. This does not restrict on diffusion, so it's likely a chronic ischemic change in the right posterior putamen. There was some hyperintensity in the subcortical and periventricular region in the temporal lobe over there, better demonstrated on the flare sequences. No structural abnormality. Cannot appreciate any significant volume loss, possibly in the occipital and temporal regions, but the frontal lobes were normal. No mineralization in the area of the putamen over there, no hemorrhage. Corpus callosum is slightly reduced in volume. Angio did not demonstrate any focal narrowing or abnormality. The neck vessels also were normal. So yeah, sorry. This is the second scan, but
yeah.
Yeah.
Meanwhile, the child, since last 1 year, she's doing well. She has no, she had no further seizures. So our doubt is whether is it DV, developmental venous anomaly, or the FCD, focal cortical dysplasia, based on
So,
the treatment varies.
yeah. So again, you have the gliosis over there in the right vital posterior putamen, and on post-contrast study, you can appreciate that the imaging, the enhancement pattern, and also on the SW images is typical for a developmental venous anomaly. There is no focal cortical dysplasia per se. These are changes attributed to the DVA.
Okay.
Is the child having seizures though?
Yeah,
No, sir.
having seizures. Okay.
Child did not
Sorry.
have seizures. That last episode, in the last year, we treated with oxcarbazepine. Since then, she never had any further seizures.
And this delta activity, no definite spikes. Anyways, yeah, I don't see a focal cortical dysplasia either.
Yeah.
How do we explain the lentiform change?
Yeah, that was the only thing. It's typical of a focal cerebral arteriopathy kind of an impact SCA.
It's not the right distribution for an FCA though.
No neurocutaneous markers, sir. No neurocutaneous markers. So for then the cause for that hyper signal change in the posterior putamen right side.
I think it's small vessel ischemic change, but you have to tell us what has caused it. Steel phenomena for
This is still ischemic until proven otherwise, and whether it's a small occlusion of some description, I don't know whether it relates to the DVA per se. It's not far away from where the DVA business is happening. But it hasn't completely reversed itself. So it is still ischemic. Arterial or venous, we can't do.
Is the DVA that part is being drained by this venous this territory? So then whether it is causing any kind of steel kind of thing and causing ischemia, but this is not a new impact also.
No, it's not.
No, it isn't.
So we're not really able to
Actually,
explain.
and actually, I don't know how much of the DVA is involving the lentiform nucleus per se. I can't tell from the images, but it seems to be away from it, right? Nihaal?
Yeah, I think, this is more of a anastomotic vein type of territory, and that is more along the straight sinus.
Okay.
Or
Because initially the episodes did look like TIA, but when we did the EEG, that was showing just delta, which can be in a ischemic kind of situation also. And because we were not sure what we are dealing with, whether they are seizures or whether they are TIA kind of episodes, we put the child on oxcarbazepine. After that, these episodes have completely stopped because initially this was labeled as FCD on the MRI.
No, there's no FCD.
Oh, thanks.
To summarize, this putaminal lesion, just for me to learn, this putaminal lesion is responsible for the clinical situation 1 year ago? Or is that kind of incidental finding? Would that
But it
make
looks
type of seizures?
incidental because that time there was no acute diffusion restriction in that area. Both the episodes were very frequent, almost 20. Nihal, maybe you can put more light.
Yeah, you're right. There is facilitated diffusion actually on the ADC, so it is not an acute event or an acute injury.
That's what I'm saying.
So that's why we actually thought that this FCD-like thing, which we were not sure whether that was just causing seizures, and that's why we put the child on oxcarbazepine because he was getting so many episodes. And after putting on oxcarbazepine, there are no further episodes, which actually supports that these may be seizures only.
No, yes, but you don't know where it comes from.
Yeah, exactly. But the delta which was seen was in the same site.
Okay.
But
So
somebody
whatever
has
that-
told us that there are no seizures.
No, now there are no seizures. After putting the child on oxcarbazepine, those events have stopped. So we are presuming they were seizures. Though initially we were thinking of like TIA kind of episodes. But after putting on oxcarbazepine, they have completely stopped. So now we are wondering whether there is any focal, cortical dysplasia sitting there, because just the DVA may not be sufficient to explain these seizures.
So
Neither the
yeah,
pitaminid.
in 20% of large DVAs, you can expect to see some cortical, organizational, or migrational problems. But then the semiology should match a particular location. Are you able to localize it based on the seizure type?
No, actually, it's just having loss of tone in one limb. So that was also very unusual. Usually, I mean, if we get some focal tonic-clonic seizures or focal dystonia, that will be more typical of the temporal lobe or automatisms kind of thing. But here, what we were getting is just complete loss of tone in one limb. So that's why we are still not very sure whether it is still a steal phenomenon and it has just incidentally stopped after oxcarbazepine, or is it really a seizure focus there, which may be micro-architectural, not really looking like a dysplasia on the MRI. And as you said, with the DVA, it may be associated.
The question is for channelopathy, Dr. Rohit, by Dr. Sunil. See the semiology.
So many, I mean, MRI findings which
Yeah,
are
yeah.
completely unexplained. We have not yet thought about channelopathy. And with focal findings on EEG, focal abnormalities on the MRI, all on the same site, we're still trying to figure out what exactly is going on there. Yeah. So what other imaging can help us to, be more sure about what we are dealing with?
Pankaj, would you do a PET MR or is it not required?
Not at this point. I mean, we haven't still localized clinically what's going on. Are these focal seizures, for instance? All you've described is loss of tone, like drop attacks, right?
Yeah, loss of tone in one limb only. So his one limb
Yeah.
becomes completely hypomotor. So it may be a seizure. It may be a TIA kind of episode, but
Were you able
more
to
likely
get
to
a-
be seizure.
Were you able to get a video EG during the episode? Was the child admitted like when she had
No,
those
no,
multiple
the-
episodes? Okay.
No, we were not able to catch the episode because
Okay.
it was done after starting and the episodes already stopped. But we did get a lot of delta in that region. Yeah. So any role of doing the perfusion study, I mean ASL and so on, or if the episodes recur, then will any imaging be able to
You
help us
will get
further?
you might get a perfusion difference by virtue of the fact that there is a DVA sitting there as well. So that might be a red herring or a false kind of finding really in this context.
Okay.
Are you planning to consider doing a prolonged EEG or something else from that perspective? That might be a better place to start. And then if it localizes or lateralizes, Nihaal is right, we should do a PET to kind of confirm those changes and perhaps repeat the epilepsy protocol MRI scan as well with high resolution T1 and flare.
Okay, thanks. Because we are
But
just
no-
waiting. If they recur, then we should be ready with the plan what to do. Thanks.
All right, thank you. Ravamani.
Yes, sir. So this is another child, 10-year-old boy, normal birth and developmental history. He came with a complaint of unable to hear from right ear since 3 years, which is progressed over these 3 years, and left ear is normal. He's saying no other ear issues like discharge or any trauma or any swelling or anything, or any other systemic manifestations he had. The family history, maternal grandfather also had hearing loss. On examination, Dennis test showed right ear hearing loss, and also on investigations, he came with the outside investigation of Puton audiometry, which showing right ear profound hearing loss, and the left ear is completely normal. So they referred to us, and MRI brain was done, which is from outside.
At what age? How many? Same age?
So this was done last means 9 years of age.
Okay.
9 years.
Okay, so we have flare images and multifocal hyperintense changes in the subcortical superficial white matter, predominantly in the frontal lobes and also in the parietal regions. Cannot appreciate any structural malformation on the flares, at least the film images. No cystic changes or rare factory changes, but again, the temporal poles have these hyperintense foci, multifocal hyperintensities in the bilateral cerebral hemispheres with predominance along the peripheral region of the brain. No structural malformations, no significant volume loss. Posterior fossa structures also do not demonstrate any abnormalities. These are the changes on the flare. T2s, again, the hyperintense foci, which was seen on the flare sequences. Cannot appreciate any structural abnormalities, no malformations per se, but again, the images are from the film. There is a mild reduction in the brainstem volume, especially the midbrain, possibly some minor dysplasia of the corpus callosum. There's a question of temporal lobe sclerosis. I think there's a incomplete hippocampal inversion on the left side rather than atrophy. This is actually artifactual, which is not seen on the flare sequences. So possibly some minor degree of prominence of the folia over there, folia pattern over there, and the superficial regions. But the main changes, what we thought of, are the multifocal hyperintensities in the cerebral white matter on both sides. Yeah.
Nihaal, I missed your point. Any abnormality in the petrous bone or at the inner auditory canal? And do we know, is this sensory neural hearing loss or conductive hearing loss, or a combination?
Sensory neurals.
Sensory neural on right side. I cannot really appreciate the nerves on the T2s, but Gamani, anything on the report that they mentioned?
So, they reported as bilateral temporal horns are prominent with bilateral hippocampal atrophy.
No, not along these, the temporal bones, the semicircular canals or the internal canals.
No.
Facial nerve. Okay. Yeah, I would thought of these differentials based on the progressive or static nature of the neurology. RNAs, T2 skin, CMV, again, very non-specific, at least to what I think on the images. It can be also chromosomal. So I'll open the case for the panelists.
I don't know the answer, but these bilateral lesions do not explain a strictly unilateral hearing loss.
Yeah.
I think we need to focus more on that hearing or more on that petrous bone.
So, Dr. Eugen, what exactly regarding the petrous bone?
I don't know whether you have done a high resolution image of the petrous bone to see the inner ear and the cochlea and so on, whether there is a lesion there perhaps, or in the auditory nerves. I mean, you have already now a history of 3 years. If you would have something like, I don't know, NF2 or a mitochondrial disorder, you would expect a bilateral lesion, wouldn't you? I mean, I'm concerned. I don't know the answer, but I'm kind of unsure about this strict unilaterality. And by bilateral white matter lesions, sometimes you see this as an incidental finding and not really impressed whether it's of clinical relevance in this particular situation. This child goes to school, has normal cognition, has normal neurological examination. No?
Yes, sir. Normal neurological examination except that hearing part. Cognitively, he's doing good.
Brahmani, was his temporal thing done? CT?
No, ma'am.
Okay.
HR, it is advised but not done.
Okay.
But there is a strong family history that maternal side grandfather is also having a hearing loss.
Yeah, but why is it only unilateral as to where levels are looking? Shouldn't it be bilateral if it's something genetic, as Agnes pointed out?
No, but sometimes it may be asymmetric and maybe more on one side. But in this child, we of course did not find any deafness on one side. But
And no
that
neurocutaneous.
unilateral does not rule out underlying metabolic.
Okay.
That's what I would say. I mean, the other experts can opine on that.
Yeah.
No neurocutaneous markers, sir. Sir, any temporal cyst, bilateral temporal?
Oh, they're not cysts, but they're hyperintensities.
It was mentioned as cysts actually.
Yeah, the cyst should be of the signal closer to CSF, but these are actually hyperintense on pairs. So I wouldn't term it as cysts. I think maybe that's why they thought of CMV, the possibility, but they're not cysts.
We will get the CT temporal bone done and then get back. Yeah.
Sure. Okay.
Thanks.
All right.
Thanks.
Thank you. Next case, Geeta.
So this child was a 3 weeks old female baby born to non-consanguineous with significant obstetric history like previous 3 abortions, born late preterm, and there were no immediate neonatal issues. At 21 days of life, presented with excessive cry and recurrent left focal seizures, and also there was drooping of left upper eyelid. So on examination, there was a mild pallor present encephalopathy. The anterior fontanelle was mild, like bulging, but not non-pulsatile, and there were paucity of movements on the right side. So we got a first MRI done after this. Child was admitted.
Yeah, so this is the first MR after the initial episode, and you can appreciate there's predominant findings on the left cerebral hemisphere. You have this subpile focus of hemorrhage or hematoma in the left temporal lobe, extending up to the parietal regions with adjacent areas of restricted diffusion or cytotoxic injury in the posterior frontal temporal regions and parietal regions. It is causing midline shift with subpulse and herniation. There are also some foci of cytotoxic injury in the right cerebral hemispheres, the temporal and occipital regions. Subdural hematomas along the bilateral posterior convexities. On the SW images, you can appreciate the hemorrhagic findings more clearly. Subdural along the falx cerebri, the bilateral parietal lobes, subarachnoid hemorrhages also along the bilateral parietal and along the Sylvian fissures, especially on the right side. Again, a subpile hematoma on the left temporal lobe. And you can appreciate the midline shift on the coronal sequences with some area of descending transcendental herniation on the left. The MRV was done, this was a time of flight MRV, not a contrast. So do not say if it's a partial thrombosis or because there was subdural hematoma causing obstruction over there. But there is some degree of flow along the proximal segments, distal segments of the suprachiasmatic sinus. Yeah, the imaging findings, the primary findings was the subpile hemorrhage in the temporal lobe as seen on this case and also in the index case, which is known to cause infarction because of the pressure of the blood on the veins along the peripheral regions of the brain. And at that point, we thought of the same paper was with the possibilities of neonatal intracranial hemorrhage. Geeta, any idea what was the cause for the abortions in the previous?
No, sir, it was all first trimester abortions only. There was we didn't get any answer from that.
And any bleeding hematological abnormalities?
No, but just prior to that, there was prior to this delivery, there was antepartum hemorrhage. Only it was very mild, not significant enough.
So hematological workup for the child is not did not give up
Coagulation
anything.
workup and all we have done, and it was normal.
Okay. Yeah. So before we go on to the next scan, Peeta.
So next, like as a child, was not much like respiratory pattern, everything were fine, and pupils were normal, and there was no heart rate fluctuations, and we like child was managed conservatively. But later on, the child developed persistent convulsions, electrographic seizures, and was started on midazolam infusion. Later on, because of the infusion and all, we had to intubate, and there were poor respiratory efforts also. Later on, we have weaned off from the midazolam drip. But throughout the stay, child had very persistent fevers, and culture was positive for Burkholderia, and antibiotics were given. We couldn't do the CSF for this child, and the child was discharged on oral feeds and IV medication, and there was no active issues later on. And we have done a repeat MRI brain after 3 weeks, and we couldn't do any ophthalmology workup also for this child.
So the repeat MR, we thought would not show up much, but it's demonstrated significant progression. I mean, significant subdural collections with some fluid layers along the posterior aspects. There is significant reduction in the brain volume, multicystic encephalomyelitic changes in the bilateral cerebral spheres. You can again appreciate the hematoma over there in the left temporal lobe. Again, some areas of cortical lamina necrosis, encephalomalacia reduced completely, significant reduction of the brain volume with the subdural collections on both sides. Yeah, and again, these residual hemorrhagic foci, which were again demonstrated on the first scan, are also seen here on the SWA sequences. Again, venography had some pastoral classification, but I think that is possibly due to the pressure effect by the subdural collections. And nothing on the orbits, they cannot appreciate any orbital hemorrhage. So if you focus on the subdural collections, these were the differentials sort of, is it post-infective sequelae or post-sepsis related sequelae? But at least we didn't come across a case with significant progression in a period of 2 to 3 weeks. So possibility of metabolic or inherited disorders were considered. Abusive head injury can also present with some features, but I'm not sure of the progression of the on the interval scan. And these are the mimics again, which was seen on the previous slide. They do not have any hair abnormalities or hair shaft abnormalities. So main case was another possibility, but clinically did not match, and they were not only the correlation with infection. But the question was, is this purely related to infectious sequelae or underlying? Is there some other underlying abnormality associated with the imaging pattern and the clinical findings?
Head circumference was normal sometimes.
Can you go back to the story, Nihaal?
And here one more thing was, it was a left-sided lesion, and we also, child had left focal seizures on the same side.
And just go on to the images slowly, one after another. This could, when I first saw the picture, I was thinking, is this going to be a subpial hemorrhage, which could be related to the birth itself? You know, the spontaneous superficial subpial hemorrhage that we talk about, yeah?
Yeah.
Now, the seizures can be explained by that. And I believe the other venous sinuses were patent on that first scan, as much as we could tell.
Yeah.
There is some subdural spacing that you see going around. And I don't know much about the venogram that you're showing in the end, how much is attenuation secondary to the hemorrhage sitting around it.
Yeah.
Yeah. And then after that, what happens?
Because Kish, we had a very similar case about a year or so ago. Do you remember?
Yes, yes. And then what? Hi, Yale. Good to hear your voice, by the way. Is that the last scan you have then, or you were showing some subdurals in the atrial? Is this when is?
So this is after 3 weeks.
After 3 weeks, okay. This is a very severe subpial only. I've not seen subpials go this way. I
Yep.
think we have to think abusive head trauma quite strongly here, frankly, because the damage in the brain is bilateral, isn't it?
Yeah.
And the subdurals with such atrophy, gliotic injury, which is regional as well as global. And considering that the child was only 21 days old, they already have a very low threshold for hemorrhages in subpial, subarachnoid, subdural locations. So if we just kind of reflect on the first scan, where all do we see the hemorrhage? It's
Predominantly
everywhere.
subpial, yeah, but yeah, it's everywhere. Subdurals are almost everywhere. Subarachnoids too.
And on that, did you have a diffusion?
Yeah,
Were there any retinal hemorrhages?
the optal wasn't assessed.
Because to have such a degree of kind of NAI, you would expect retinal hemorrhages, no, in this context?
Yeah, if it was checked at the right time, because
It
retinal
wasn't.
hemorrhage,
It wasn't checked. There was no optal examination.
yeah, so we don't know. Now, I think it was Sunil or somebody who said it's a precious child, but I don't know what are the differentials we can offer. You probably will end up screening for entities like Menkes and usual things that present like that. And somebody asked about hemorrhagic disease of the newborn. A vitamin K was given at birth. That is also relevant.
Yeah, it was given at birth.
Are you all planning a skeletal survey, but that may not show anything more?
Skeletal service was normal.
Geeta, was the mother unapparent? Any idea?
No, sir. She didn't have any issues.
It's quite extensive for any organic acidurias, right? Because they can cause hemorrhage, they can cause infarcts in the brain like this.
Yeah, if the hemorrhage wasn't that significant, maybe the molybdenum cofactor sulfur oxidase stuff, but the hemorrhage is too significant, I would say.
Yeah,
At
I
least
think
we have-
still you'll have to do a baseline metabolic screen, but if everything comes back negative and the diagnosis of exclusion would be abusive trauma here, right?
Yeah, so should we get a fundoscopy done, ophthalmology review, maybe?
It's good to baseline it, but retinal hemorrhages can go away in 24 hours. They don't, unless it's full thickness, and then by that, if it was full thickness and all, we would have seen something on the T2 axials at 3 weeks from there.
Kish, can I just ask a question back to this spontaneous appeal? I just remember that, because we had that case about a year ago, I can find you the name if you want to look at. You did mention at the time that you can get bilateral changes, and some of it is secondary to kind of a contralateral side.
So the subpial hemorrhage can extend into other compartments. The problem we have here is what was the birth history, first of all? They generally have a traumatic birth and things like that. Yeah. But this was born in very good Apgars, But apart from that, the compartmentalization of the hemorrhage, I can explain that. But what ensues is multifocal infarcts of different kind of dimensions and degrees all over the brain, which is too much from a subpial.
Okay, no, I was just wondering, yeah.
But if there are no social concerns, I mean, we can't keep pushing for abuse either in 21 days of life. But those are the differentials from a radiological perspective. Nihaal, did you have anything else to add to that?
No, that's.
And I guess an ophthalmological review now at this stage, I mean, if it's pristine, that would also it doesn't exclude, but it would slightly go against kind of such a traumatic shaken baby.
Yes.
So I don't think I think we've missed the boat to totally conclude for it to be conclusive. I do think that, you know, even if it can be done this week, it would be informative.
Yeah, I mean, it should be done. It should be done. Just thinking what else this could be.
Geeta, was a newborn screening done? Any idea?
It was not done.
Okay.
I think Sunil has asked some very relevant questions about, but do we have a history of recurrent first trimester abortions and things?
There were 3 abortions. I'm not sure if they were first trimester. Geeta, can you just confirm?
Yeah, they were the first trimester abortions.
Okay. And then are we dealing with some kind of rare vascular problem? Should we still be screening for col4As and 4A2s and all that? I don't think this is, I mean, it is functionally vanishing white, but I don't think this is a genetic vanishing white matter disease situation. That is somebody's differential in the chat, I think, Jordan. So it depends on how much you want to investigate. You'll have to do a proper baseline for all the vasculopathies, including the connective tissue disorders, in which collagens and col4As and all that will be covered. And then if there is definitely an extended clotting screen that's negative, the birth was not traumatic in any way, the placenta, if you have information about that, because we've talked about the mother and heparin, but the health of the placenta would be relevant. And if all that is excluded, then we are left with a situation of unexplained. I must say that against abusive head trauma here is the very predominant subpial hemorrhage pattern that we see in the beginning of time. It's not the usual predominant feature.
Okay, we'll probably work it up according to that.
I'll keep thinking about this case. If I have any more ideas, Nihaal, I will drop them to you.
Yeah. I know the parent. I mean, the parents are known to one of my relatives, so I can probably speak with them and get the extensive connective tissue and the ophthalmology done.
Yeah.
Okay.
I have had one similar situation only, but it's only one case. And in fact, they were implicated in court, but they got back, what is it, Ehlers-Danlos type 6 come back positive on genetic tests. So it could be some connective tissue problems running in the family, which is leading to these recurrent abortions as well. You will have to screen for all that.
Should we do a spine study or too late or?
You can do it. I don't think any finding there is going to change any difference.
Yeah. Got it. Yeah, the only thing the abortions was this thing is something underlying causing it. Those 3 abortions is the number is significant, I guess.
And you know, things like HIT, you know, the heparin-induced thrombocytopenia or early pregnancy problems and I think Sunil has been quite clear on asking you all to get that history correctly about heparins. It is very relevant, I think, in this particular case to get that.
Okay. Yeah. We'll do it. Geeta, just check on it, possibly.
Yeah,
All right.
sure.
Thank you. We'll move on to our next case. Ina, if you're there.
Hello. Is I'm audible?
Yeah, go ahead.
Yeah. Good evening, everybody. This is a 5-year-old child who presented with a history of a 2 weeks history of drooling of saliva and swallowing difficulty with solids and liquids. And this continued for some time. He was treated for thinking that he's having some throat congestion, and because also he had a history of adenoids, he was treated as a URTI. And then 2 days prior to admission, today is day 6 of admission actually. So 2 days prior to the admission, he had shallow breathing and poor respiratory efforts. Respiratory efforts are poor in the sense that it was less respiratory drive, I would say. He was just ventilating and he was just breathing at a rate of 8 or 9. And then they noticed that he's developing some altered sensorium in the outside hospital. So the child had to be intubated for the hypercarbia and the altered sensorium. And then he was transferred to our hospital. And after coming to our hospital, the hypercarbia improved and the sensorium also improved. So we are not very sure whether that mild encephalopathy, which was there to begin with, whether that was because of the hypercarbia or not. After admission, his sensorium has been absolutely okay. And he has developed some low-grade fever spikes. But other than that, there are some inflammatory markers elevated, like the CRP is 22 and the ESR is 40. But other than that, we did not get anything conclusive to say that there is a severe infection or anything. And as I said, there is a past history of recurrent UTIs and he's been treated for partially obstructive adenoids. But as such, it's not. The ENT surgeon said that there is no need of an operation immediately. So his past history is also significant. I mean, his development history is significant in the form that he had motor delay. He started walking after 2 years of age, and at present he can do everything. But motor-wise, he's okay. But the speech, they still say that even though he can speak everything, the speech is slightly less fluent. And another past history which is significant is the past 3 months, he has a history of hyperphagia and weight gain. So he has gained about 3 to 4 kg in the last 3 months. And this is a firstborn child, non-consanguineous marriage. And the birth history is significant that in the form that he just had some poor feeding and suck as per the mother, and was treated as probable sepsis with 5 days of antibiotics. At present, on examination, I would say even on admission, he did not have any limb weakness as such. His extraocular muscle movements were full. There was no facial involvement. Pupils were reactive and equal on both sides. And neck weakness was as such not there. And I did feel that the lower limb reflexes are slightly less. So I got an NCV done, which just showed some mildly low conduction velocities in the lower limbs. Upper limbs, NCV was absolutely okay. And so should we discuss MRI first, or?
Yeah, we'll go on the MRI.
Yeah.
So the MRI, you have almost symmetrical patchy hyperintensities involving the brainstem, the medial thalamic nuclei, the inferior aspect of the global pallidi over there, predominant involvement of the midbrain, the cerebral peduncles, coming down to the inferior cerebral peduncles over there, and also involvement of the medulla. The areas demonstrate restricted diffusion. They also focus in the left cerebellum, demonstrating restricted diffusion. The satellite images, you can better appreciate the extent of the abnormalities extending from the deep brain nuclei up to the lower aspect of the medulla. Post contrast, there was no enhancement. Spine study was done. On the left, you can appreciate there's some degree of thinning of the at least the thoracic cord on the axial sequences. I wasn't sure if this is the long segment hyperintensity is significant or not. The cervical cord did not demonstrate any hyperintensities. The thoracic and the lower thoracic cord had these central hyperintensities over there. Also, the upper lumbar cord had these predominantly central hyperintensities. No enhancement of the intermediary portions of the cord, but there was some degree of enhancement of the quadraicular nerve roots, the ventral and dorsal quadraicular nerve roots. The imaging differentials we thought of was a viral encephalitis, predominantly rhomboencephalitis related disorders. Enterovirus was thought of as a possible differential. Given the developmental history of mitochondrial disorder, such as SERF1 mutation or the tRNA disorders, was another differential which was thought. So I'll open the case for the panelists to discuss.
I mean, the one differential that I'm raising, but it's slightly unusual entity is ROHAS, this rapid onset hypothalamic and obesity, which is thought to be autoimmune. People are familiar with that.
Yes, ma'am. Actually, we had discussed with the endocrinologist regarding this. So what he thought is that they will definitely have these electrolyte imbalances also along with that. And not very sure if there would be a brainstem and the spine involvement in patients with ROHAD.
Okay, no, I agree. I just thought we should raise it for, but if an endocrinologist.
Yeah, yes, ma'am. We had already discussed that, and
Yeah.
our endocrinologist thought that probably this doesn't fit into ROHAD actually.
That's fine. Yeah. And
Okay.
I
And we
agree. The
also-
MRI abnormalities are not very typical, but this syndrome is also not very kind of, I don't know. I think that the phenotype is quite wide, so it's a bit tricky. There's
Okay.
no diagnostic test, so it's difficult to know.
Okay, ma'am. There is this, we had done the thyroid profile and the obesity workup. The TSH was low, that is in this 0.54, and the normal range is around 0.8 for this age group. And the T3 is also towards the lower side, but the T4 was normal. Since the T4 had come, the free T4 was normal, the endocrinologist thought that we don't need to replace the thyroid immediately. And the obesity workup, we did the prolactin levels and the cortisol levels. The cortisol levels slightly low early morning. And another thing which was done was TPO, which was normal in this child, and prolactin levels had come normal. The lipid profile showed slight, the LDL was slightly towards the higher side, and HDL was low 29, which is when the normal range is around 40 to 60. Other than that, actually, no other. As I have already mentioned on the screen, that the CSF fire had come negative, that enterovirus was negative, and the listeria or the other viruses which can cause brainstem encephalitis all were negative. NMO and MOG has come negative. CPK done because of the decreased reflexes which came normal. The CSF lactate is still awaited, and the COVID antibodies are still awaited. So we were also thinking in terms of mitochondrial because of the symmetry and the brainstem involvement, and the history of motor delay with head circumference being, sorry, I did not mention the head circumference. It was 46 centimeters, which was less than the 3rd percentile. So the motor delay with the microcephaly and the brainstem involvement, with the recent onset, some endocrinological problems like obesity and all, we were thinking in terms of mitochondrial also. So I was not very sure whether or not this is genetic or acquired. Already gave the child IV methylprednisolone. Today is the day 5 of IV methylprednisolone, and we have started him on mitochondrial cocktail. So clinically, he has improved in the sense that he is able to, like we put him on CPAP yesterday, and he was able, like initially we gave a CPAP trial. He failed that CPAP trial. His respiratory rate was just around 8 and 9, and then he was building carbon dioxide. So we again put him on SIMV, and then we again gave a trial yesterday. So he has now he's able to breathe on his own. So there is a that part has improved, but the pooling is still there, and there's no curve reflex yet. So I would say that with methylprednisolone, maybe there is a partial improvement.
Sorry if I've missed that. Was there any enhancement on the imaging?
No enhancement.
No enhancement.
And did he also have some spine? Because particularly, I mean, if things like Bickerstaff, I don't think it's typical for Bickerstaff, but you may expect some.
Yeah, ma'am. I actually wanted to ask whether really Bickerstaff should we get evaluated? Should we do the anti-ganglioside antibodies for Bickerstaff in this case?
The anti-ganglioside, and particularly the GQ1B. So they're very interesting. We did some work on them, about 10 years ago, and they disappear very, very quickly. So if you haven't got a sample from the first kind of week of symptoms, they're very rarely, even in patients that are positive, the antibody goes away very, very quickly. So in a way, this should really be kind of a clinical diagnosis, but you have I presume a normal CSF protein.
Yeah, the CSF protein 42. That was done on day 2 of admission. So the proteins were 42, and the rest of the CSF was completely normal. One cell, glucose normal, nothing particular in the CSF.
Yeah, so in a way, you have like 3 big, if you kind of think practically in a 3 big category, this could be infective. And in those cases, you would expect, if this is like an enterovirus, they normally do quite, badly, unfortunately, if it's the brainstem and stuff, they really don't respond at all to immunosuppression, even if we do that. You have the inflammatory one, and in that group, sometimes you need to escalate treatment either to, the reason I was asking about enhancement is that these are the patients that I would normally use plasma exchange. I feel that if there is enhancement, you have got much more to save with plexing them, but also with IVIG. And we had recently, I think 3 this year, of like slightly very atypical kind of bigger stuff that only responded to rituximab. So that's why it's kind of important if this is what we think it is. But in this case, the symmetry on the imaging does really raise a metabolic disorder quite highly on the differential. A lot of the time in these mitochondrial one, you would also expect raised CSF protein, even more than the lactate. So again, it's a bit atypical, but you know, it may be that you try to get some of the mitochondrial genetics back, and then, you know, if you see any response to immunosuppression and the mitochondrial genetics is negative, then you may decide that you have nothing to lose and you escalate the treatment to something like rituximab.
Okay.
I don't think this is a clear cut. I mean, I don't know what the radiologist said. You know, it's not a very clear cut, and sometimes for these cases, it may even be of benefit to repeat the imaging. You know, kind of a couple of weeks after, because if you have any progression of the lesion, it may give you a clue about the pattern.
Okay, sure.
Kish, do you agree? Or
sorry,
I'm just asking Kish if he agrees with my.
Okay.
Yeah,
Kish?
I totally agree. That's absolutely correct what you have just said. No disagreements there.
We normally decide those things together. That's why I need your.
Yeah, absolutely.
So at present, so I would like to ask, in mitochondrial, would there be some contrast enhancement which was seen in this case? Like some caudate 1 enhancement is seen in the spine. So can that be explained by mitochondrial, or this goes more towards acquired causes?
I don't think you can use that as a discriminating feature, even if it is real, that is, but there is always some enhancement of the blood vessels there as well.
Okay.
But for now, maybe treat for bigger stuff, do the genetics just in case. And if you're seeing any, and as I said, with those cases, a lot of the time you need to escalate treatment. So, you know, I would treat acutely like any, in a way, labeling this is nice for us, but it's a bit semantic for the patient. So, you know, if you think this could be inflammatory, we should treat for inflammatory. And before escalating to second line, which you should consider because some cases do need it, just make sure that you're not missing, at least get the common mitochondrial. I don't know, how long does it take for the common mitochondrial genetics?
It takes quite a long time. It takes about 21 days for the whole exome and the mitochondrial to come, and the fastest which we can get is 14 days.
That's pretty fast, to be honest. You know, we don't get it as quickly. But I'm just saying, so it gives you 2 weeks. So I think for now, if you feel you need to escalate beyond the methylpred, then Plex plus IVIG, or IVIG and then wait and then Plex. And then once you get the genetics back, if the child has made some improvement but not complete, then I would probably go for rituximab. I think you can send the ganglioside antibodies and things, but it's always good to do that cheap test. But you know, most of these cases the antibodies are negative.
Okay, sure, ma'am. We'll do that. And it was a non-consanguineous marriage. Sir was Dr. Lokesh was asking. It was a non-consanguineous. There is no history of abortions, or there is nobody else in the family being affected by similar problems. Okay, ma'am. That's
All right.
that's helpful.
Yeah. All right. Thanks, Hina. Thanks, you.
Thank you, everybody.
Surbi, if you're there.
Yes, sir. Good evening, everyone. So this is a 5-year-old girl born to non-consanguineous parents. She had this complaint of seizures, which started at 1 year of age, and they were always with fever. And they were always brief episodes, the GTCS type, which lasted less than 5 minutes. So initially, she was not put on any medications and treated as febrile seizures only. Considering the development also was normal, so motor as well as the cognitive development was normal. But then, because the episodes were happening very frequently, like every 2 to 3 months, and so that's why then she was put on a long-term anti-epileptic, that was valparin. But even after that, the seizures persisted. Still, the seizures were always with fever only, and they were brief seizures of GTCS semiology. The semiology did not change, and they were never prolonged seizures. In terms of development, as I told, she was a firstborn. There were no perinatal issues. The development was well appropriate for age. She was walking on time and speaking on time. Currently also, as per parents, she is not having any issues. But on examination, to me, she had a little bit slurring of speech, and she had a little hyperactivity and very mild cognitive issues. On examination, there was normocephaly. There were no neurocutaneous markers, no dysmorphism, and very mild spasticity in the lower limbs, just the hamstrings. Other than that, the reflexes, power, everything was normal, and the gait was also normal. There was no ataxia, there was no ophthalmoplegia. So they already had an so because of the persistent febrile seizures, we got the imaging, and the MRI showed doubts for. So there are the subcortical changes and the symmetrical changes, which I thought could be because of organic acidemias or mitochondrial. I asked my seniors also, and they said it looks like L2-hydroxyglutaric aciduria. So my question was, like, is it definitely L2, or should we think of mitochondrial as well with such changes?
Yeah, so the T2 images have a predominant subcortical and some deep white matter involvement, but predominant subcortical gradient involving the parietal cerebral hemispheres. The basal ganglia are also hyper intense. The dentate nuclei also have symmetrical changes. There is some degree of restricted diffusion along the basal ganglia on both sides. Yeah, the flares again demonstrate similar changes which are seen on the T280 sequences. There's reduction in the volume of the corpus callosum and also cognitive of the midbrain. I think this was a previous scan.
Yeah. This scan was done at 1 year of age, I think.
Yeah, which again demonstrated similar imaging findings. Subcortical predominant white matter abnormalities, confluent abnormalities, basal ganglia abnormalities, and dentate nuclear abnormalities with some degree of volume loss of the cerebral hemispheres on both sides. So if a differential on imaging itself, L2-hydroxyglutaric aciduria would be on the top list, with Kearns-Sayre syndromes, propionic acidemia, urea cycle disorders, and type A1 mutation as a possible differential. So again, the imaging pattern are again Kearns-Sayre syndrome. I don't think the child has ophthalmoplegia or any pigmentary retinal changes, but they can also present with subcortical involvement of the white matter and also deep brain nuclear involvement. L2-hydroxyglutaric aciduria, as just seen in our case, has dentate nuclear abnormalities, subcortical predominance, and can also have basal ganglia abnormalities. TACA-A1 is usually seen in the more adult age group, but they can also have subcortical involvement. We focus on the dentate nuclei, again, as seen in our case, L2-hydroxyglutaric aciduria is a prime differential with mitochondrial disorders as a secondary possibility. So at this point, I'll open the case for the panelists to comment upon.
For me, this MR is diagnostic of 2-hydroxyglutaric aciduria. I cannot think of another alternative. You can measure this compound in the urine if you have access to organic acids, and this compound is often up to 100 times elevated. You can then, if you have money, proceed to genetic testing, because the urine result does not distinguish between L and D2-hydroxyglutaric aciduria.
I completely agree with Prof. I think this imaging is very classical for L2-hydroxyglutaric aciduria. What's the head size, Surbi?
It's normocephaly, so 49 centimeters for a 5-year-old.
Usually they have relative macrocephaly.
Large size, yeah.
Yeah, so that's the usual handle in these children. And mild delays, ataxia, intellectual delay. That's usually they don't behave like a usual other progressive leukodystrophy kind of presentation. They are very stable for long years. We have a child who has just started college at say 17 years with L2-hydroxyglutaric aciduria. And the levels of the L2-hydroxyglutaric aciduria in urine might be just borderline sometimes, 6 times, 10 times elevated. But if you do a genetics, it will be easy the diagnosis. But I think that's what it is very likely.
There is some controversy, I think we have discussed it before here some time ago, about surveillance, because a few patients with this condition have been found later have brain tumors.
Yes, some teratogenicity has been associated.
Okay, Dr. Mankad says radiologically nothing else, so save the money of the patient.
Okay, yeah. Thank you. Thank you, everyone.
Yeah, all right, thank you. To our last case, I think, from Delhi.
We had
Tanuja,
a 1 year, yes, sir.
Yeah.
1 year, 5-month-old male child with a normal birth history, birth weight being 2.6 kg, came with delayed milestones. Child first presented to us at 11-month age and had epileptic spasms since 3 months of age. At 9 months, the child was admitted for seizures and UTI and was found to be hypertensive. Child continued to have clusters of spasms up to 50 spasms per day and was on vigabatrin. The first MRI we did at presentation, that is at 11 months. Presently, child is 11.8 kg baby, slightly large, and spasms have reduced after increasing the dose of vigabatrin. Child is still hypertensive and is maintained on antihypertensives. So the second MRI we did at 1 year, 5-month age.
Yes, but I have only one MRI. Which one was this? Is this while the child was on vigabatrin?
Sir, actually, we had sent both. This is the first one, sir. This
Okay,
is at
so,
11 months age.
Okay. So have the changes resolved now on the second MR?
Yes, sir, resolved.
Okay. So yeah, sorry, I don't think I had the second MR, but maybe I missed it. So on the first MR, you have cerebral atrophy and symmetrical changes in the deep brain nuclei, the brainstem. These are the dentate nuclei demonstrating restricted diffusion. No abnormalities on the SWA sequences. Corpus callosum slightly thin, slightly plagiocephalic head on the posterior aspect. Spectroscopy demonstrated elevated lipid and lactate peaks with slightly elevated choline peaks, of some inflammation and some anaerobic metabolism going on there. So I didn't have the second MR, but based on the first MR and given that the child was on vigabatrin, the changes were likely related to vigabatrin-associated brain abnormalities, which can present with these symmetrical pattern of involvement in the deep brain nuclei and the brainstem, and also in the cerebellar white matter and dentate nuclei. So sequencing was done, and Anuja?
Yes, sir. Mitochondrial and clinical exome sequencing was done, and it was negative. This was done because initially the history of vigabatrin was not forthcoming. So on retrospect, we got to know that the child was on vigabatrin. But another query of us was the cause of hypertension, because on evaluation, we have not found any cause of hypertension. So any feature on imaging which could suggest the cause?
Okay, just to round off, the ADGRV1 is not many cases, but they are usually known to have normal MRI or some degree of cerebral atrophy. So yeah, just to round that off, but at least on the imaging, I don't know if we can comment on the hypertension. There were no press-related changes or hypertensive-related changes. No hemorrhage.
I mean, there is global volume loss, but that can be seen in any of these tests.
Yeah.
No, he was not on steroids.
But they had multiple seizures, right? And spasms.
Yes,
so that can
yes,
cause brain atrophy. But nothing indicative of hypertension in the brain. Dr. Monkar, do you agree?
Yeah, I totally agree. What we are seeing is probably neurodegenerative from the seizures and or the mutation that you're describing, but not specific to imaging. It's a pity that mitochondrial testing was done because this is so straightforward by vigabatrin, isn't it?
Yeah. All right, Tanuja, we don't have any clues for hypertension on the brain, but yeah, the changes are typical of BABAM. Yeah. All right.
Okay, sir.
Thank you. I have 2 follow-up cases from previous sessions. We'll quickly go through them. Ramani, if you can quickly.
Yes, sir. So, sir, this last time we discussed this 11-year-old male, normal birth and development. He had at 5 years of age, he was diagnosed with pre-B-cell ALL, and then he received the chemo. After the completion of chemo therapy, he again relapsed. That to CNS relapse after 1 month of completion of his complete chemotherapy. So for that CNS relapse, he received chemo and radiotherapy. And then after 1 year of second relapse, he had after 1 year of relapse, he diagnosed to have a CNS TB, and for which he received AKT again for 18 months. And during the TB AKT treatment, he developed left eye loss of vision that was diagnosed as optic neuritis, probably ethambutol induced or autoimmune induced optic neuritis, for which the first MRI was done when he came with the complaint of poor eye vision. That was in last year 2021. So should I directly go to the progress?
Yeah, so I'll just show the images sequentially, and then you can discuss the recent scan.
Yes.
So this is in April 2022, which we have discussed in October. This child had gray and white matter involvement, extensive involvement in the bilateral cerebral hemispheres, also the brainstem and the posterior fossa. Some areas demonstrated restricted diffusion, especially in the thalami and the brainstem and the vermis.
Sir,
in August.
April, the first MRI you're showing April 2022. By that time, he came with the complaint of gradual encephalopathy. Like he was drowsy since almost a week. He presented with that complaint. That time, April 2022 MRI was done. And this time, again, he came with another episode of encephalopathy.
Did he have the MOG antibody tested?
We tested, ma'am, that's negative.
Yeah, so I'll just go through the images quickly. So again, extensive changes, some progression of the abnormalities, especially in the frontal lobes, the basal ganglia, temporal lobes are there, and some degree of volume loss along the superficial aspects. Optic neuritis was mentioned, and there's left optic neuritis. You can see on the coronal images, there's a perineuritis of the left optic nerve. In October, again, the imaging, there was a progression, now more confluently involving the basal ganglia, the perisylvian regions, the frontal lobes, the brainstem, and also some areas of the cerebellum. Now, these are the present images. Before we go into the images, Brahmani, anything to any new presentations?
Yes, sir. So he, all this 4 admissions, 4 MRI scans, 4 admissions, he presented with the encephalopathy pattern, and we CSF to rule out any relapse or anything. All the time CSF counts were normal, and it was we ruled out all demyelination, MOG, NMO, everything was normal, but there is a progressive leukoencephalopathy. So we thought of doing PET also, but we couldn't do that because the child was intubated and on mechanical ventilation, and this time he required even inotropic support, went into septic shock, developed candida, sepsis, Klebsiella sepsis. So we thought of sepsis related also. But then the last CSF recently we done, which showed 90% blast. Previously, we discussed what could be the cause for these progressive changes. That time the CSF counts were normal, but now the CSF has shown 90% blast.
Yeah, and on the imaging also, you can appreciate there is, again, look at the white matter changes are significantly progressed, also the deep ray changes. But the cranial nerves, if you see on the diffusion, especially demonstrate this thickened appearance with restricted diffusion, the optic nerves, the facial nerves, vestibular nerves, trigeminal nerves over there. So there is infiltration, leptomeningeal infiltration, almost involving most of the cranial nerves. Some area restricted diffusion along the insular cortex. The spinal cord demonstrates this bumpy appearance, which will be better demonstrated on the post-contrast study. But again, they have the cervical cord abnormalities. Post-contrast better demonstrates the abnormalities again. The bilateral optic nerves and the optic tracts are bulky, demonstrating post-contrast enhancement. The trigeminal nerves again have these enhancing, they demonstrate enhancement and are thickened in appearance. Some leptomeningeal enhancement along the vermis. The vestibulocochlear and the facial nerves also demonstrate thickened appearance with post-contrast enhancement. So again, the multiple cranial nerve involvement, multiple areas of nodular enhancement in the cord and the lower half of the brainstem, also involving the thoracic cord. No seeding of the around the caudaico nerve roots, at least on the post-contrast study. So these findings are suggestive of an infiltrated disorder, and as the CSF has pointed out, a possibility of a CNS relapse was most likely. Is that right, Ramani?
Yes, sir.
Yeah, if anyone wants to comment upon the imaging and the clinical aspects of the case.
Yeah, so the question was whether the initial scans where we were not really able to find out the cause can it all be explained by just leukemic infiltration? Because that time, at least once we have done a CSF, which was normal, there were no malignant cells. And the child just had very unexplained kind of encephalopathy. He was mostly drowsy all the time, and we even treated him like some paraneoplastic immune-mediated affection, and treated him with even rituximab. After a lot of discussion, we even discussed here, and it was thought that it may be immune-mediated. So retrospectively going, now that we have a CSF loaded with blasts, and now there is almost very good evidence of metastasis all over the cord as well as the cranial nerves. Are these changes actually indicative of leukemic infiltration alone, or maybe this was something else and now there is a relapse? Am I audible? Sorry.
Yeah, Dr. Pita, I don't
Yeah.
think we had contrast in all, but I don't, going back to at least the cranial nerves back then, they did not, I mean, they look up normal in caliber, not thickened. There was optic neuritis, but if you see the most previous scan, it is more bulky and rather than only neuritis. So possibly in October, you can see that the proximal aspects of the optic nerve are slightly bulky over there. And also there is some edematous changes in the facial nerve and the cochlear nerve. So maybe
because a lot of
in
possibilities we had discussed that time.
Yeah,
it may be radiation therapy related, it may be some chemotherapy related, or a lot of
the nodular cranial nerves, etc., very typical for relapse. But the white matter changes that became like that are quite unusual for CNS leukemia, because eventually you have cortical as well as white matter. White matter is hit. So
yeah, we even thought of PML and all that, but CSF was completely bang normal at that time.
So I couldn't put the white matter changes together in that respect, unless they have some kind of a viral process going on in the background as well, which the CSF may not pick up. But if it's a slow virus related to immunodeficiency, for instance, we see that in the context of HIV and SSPE kind of situations, right? The extensive white matter changes.
And even in PML, you very rarely pick it up in the CSF. You normally pick it up in biopsies. So
yeah, we did not do a CSF PCR for JC virus, but HIV was negative. Before giving the last resort was rituximab that we gave, thinking of this as an immune-mediated kind of pathology. But ultimately, of course, deteriorated, has a lot of secondary infections with even mucor and aspergillus and all those things. And in the end, when we did the CSF, after this scan, of course, that showed almost 90% plus.
Now, do we think there could be a second process, even now in the retrospect, with those, if radiologically the white matter changes are not typical for CNS relapse? Do we think that he could have a virus that got worse with the rituximab and everything else, or?
Yeah, that's what we are thinking. Whether we actually made
is
some
this a
infection
child that
worse
should
with,
have metagenomics or anything for a biopsy? Just because if you now presume escalate immunosuppression for the leukemia, are you worried that we're missing something else?
Yeah, actually, now to the child was on palliative, and ultimately they took the child home when he became very bad, and we gave a diagnosis of the relapse of leukemia with metastasis and all that. So then, I mean, because for almost 2 years we have been with this child through his journey of, and he actually came out of the leukemia and then had this CNS related issues, which we never thought of was a leukemia relapse. But as you said, that probably there was some kind of a slow viral infection like thing going on, and now after rituximab it got flared up, as well as this, because of his underlying immune issues, probably the leukemia also relapsed. So, but this was very unusual for us to really, without a biopsy, we really don't know what exactly has happened here.
And with the white matter changes, sometimes we see children that get, immune problem following, years of vincristine and stuff. I always feel like it's not totally biological, but I always feel like, once the white matter had some injury, the susceptibility of like having white matter involvement is a bit higher, in a sense that, if we see immune mediated problem in those post vincristine leukemic children, they tend to be more florid, and I think it's like a second hit to the white matter.
Okay. So there were multiple factors
in this
child,
case, it doesn't. If he's palliative, there's not much else we can do now.
Yeah.
But I don't think you can rule out two biologies here.
Exactly. Because we didn't get the opportunity to do a biopsy.
I think it's more likely than not that you have two processes here.
Also, from the optic neuritis point of view, do we think that, I don't know, what did the fundoscopy look? If it's infiltrative or inflammatory looking disc, that could have also helped you differentiate some of the.
Initially,
this is a
all the fundi was
demyelinating
normal,
optic neuritis or infiltrative one, a bit more like you see in sarcoids and things.
So we didn't particularly look at optic neuritis per se, though the fundus was initially normal, but we never did actually any VEP or for that matter. Even vision assessment was very difficult because he was almost always sleeping. So clinically, we did not actually go into really looking for optic neuritis that time.
Right.
So why we just wanted to present this follow-up is that, ultimately that is what we found as the end result, but we still don't know whether these lesions are due to that process or maybe some other collateral process going on, either immune mediated or some infection. So just a lesson learned that probably next time we'll be more careful to look at the cranial nerves from the beginning and look for evidence for other demyelination going on, as well as maybe do a biopsy early rather than late to know what is exactly going on. So thanks.
Yeah, thanks, Dr. To our last case, I don't know if Dr. Prerna is there, but this was discussed last month. I'll quickly go through it. This child was an 8-year-old with ataxia imbalance since last 2 years and had progressive worsening of the eye movements since last 3 months. There was poor memory and school performance and was born to a second-degree consanguineous marriage. The maternal aunt also had similar presentation with ataxia and was non-ambulant by the age of 15 years. On examination, child had oculomotor apraxia and nystagmus. There was no nystagmus. Telangiectasia was mentioned, but we're not that convinced that if there was telangiectasia or not. DTRs were present and the Romberg and cerebellar signs were positive. So the child had the scans across 1 year. This is the earliest scan in 2021, and you can there was a diffuse generalized cerebellar atrophy, and on the follow-up scan also you can appreciate that there is again cerebellar atrophy with the supratendoral structures were normal. So primary findings of cerebellar atrophy and the genetic sequencing was done, and what they got was the gene for APTX1, which is responsible for early onset ataxia with oculomotor apraxia. And the imaging findings and the at least pathogenic variants for the imaging findings also corroborate with the gene. So yeah, that's the follow-up for the case. If there are no
just to add, Nihaal, that when this case was presented, it was mentioned that alpha theta protein was normal.
Normal, yeah. So thanks, Dr. Prerna, for the follow-up and the final diagnosis. So that's it for us for today and for this year. Thank everyone, our panelists, Dr. Manka, Dr. Hagen, Dr. Suhasini, and all the contributors and presenters.
Great cases. Thank you.
It was great to be with you.
Thank you.
Yeah.
Happy New Year.
Happy New Year.
Merry Christmas.
Yeah, Happy New Year to all,
New
and
Year.
thanks, Nihaal, for another year of
Merry
great
Christmas.
learning, and we look forward to more. Thank you so much.
Yes. Thank you. Thanks, everyone. See you next year virtually and more in person. All right.
Bye-bye.
Thanks. Bye-bye. Thank you.